All right, so biliary labs. So we'll use yellow for this one, right? So we have total bili being elevated greater than 2.5. That is going to make you jaundice, right? So their skin color is not white. It might be difficult to see jaundice, but we can look at the sclera, and that can tell us that we have a jaundice patient on our hand. They have an elevated T bili. You can bet money that they have a T bili that is elevated, right? And the whole purpose of that is because, or the whole reason for that is because the biliary tree is broken, right? So the liver still creates what? Still creates the bile, hopefully gets stored in the gallbladder, but we're going to see that rise in the T bili because it's not able to get out of the biliary tree. All right, so T bili goes up, and we can measure it. There's a direct form and indirect form. We're not get too detailed on that. Basically, you have there's reasons why your bili could go up because you have like blood hemolysis. That could be a reason why your bilirubin might go up because your body gets rid of dead RBCs all the time. Right, you're losing like 1 trillion RBCs every second. All right, it's a little high, but you're losing a lot of RBCs every second, and we need to neutralize it, right? So we neutralize it and we bring that over to the liver to neutralize it further. It goes from indirect to direct, or unconjugated to conjugated bilirubin, and then we form the bile to be then processed, or held, I should say, by the gallbladder, right? So T bili goes up for that reason. RBC breakdown is another good reason. And then what else? So Alk Phos. So Alk Phos is found in many different areas of the body, right? The bone especially. But when we have a Alk Phos that is elevated along with a bili, that's really leading us towards thinking that it's gallbladder involved, because it makes sense. The T bili is elevated and my Alk Phos is elevated, which Alk Phos is produced by many proteins. It's an enzyme, or cells, I should say. It's an enzyme that's found in many cells, but those two together really kind of seal the deal that I have a gallbladder situation. Okay, if Alk Phos is just raised on its own and the T bili is normal, it came from somewhere else. And the second choice I would think of would be bone, right? Because Alk Phos uses the bone a lot, and then they're thinking of like bone cancer, unfortunately. All right, so then what else? So GGT. So GGT is a lab test you have to add on to see if they have that means the biliary tree is under stress. So you have inflammation or blockage of the biliary tree itself. That's going to produce this enzyme GGT, or this protein GGT. I think it's an enzyme as well as a transferase, but it's going to be risen just in biliary obstruction. So it's very specific just for that, which is nice. So you're like, I don't know, T bili's borderline, and this is that and that. And he's like, well, can we do a GGT? That would tell you exactly that it's the biliary system that's at fault, right? Because we know there's other reasons for Alk Phos to be elevated. And when we have the liver start getting involved, we start getting AST elevated, and that's only with, I should say, with choledoco, and of course with ascending cholangitis. You're going to have AST, ALT involved because now the liver can't get rid of its stuff, right? And it starts backing up, it starts getting congested, and it can't do its thing, right? So it's AST, ALTs start going up, and he's like, oh shoot, it might be hepatitis, because hepatitis has T bili positive, right? And it will also raise your AST, ALT, but the Alk Phos being elevated also, that's kind of really pushes over the edge to think we have gallbladder situation. And then really to seal the deal, that would be the GGT, to say that's the only reason why that would be produced was because we had gallbladder blockage, or sorry, gallbladder tree blockage. Okay, and then ascending cholangitis, our worst case scenario, we're seeing a profound elevation. We're seeing profound AST, ALT, like greater than 1,000, right? Usually AST, ALT normal is 40 or lower. So the AST, ALT is like 200, 250. There's something going on in the liver or elsewhere. But if it's like more than 1,000, there's really no explanation besides the liver either has been shocked, meaning like they're in a shock state, or that they have a ascending cholangitis happening. And as you can imagine, all that bacteria is wreaking havoc as it goes to the liver. And as we do cultures, because we should, we have a shocky patient, a tachycardic febrile patient, all kinds of sepsis protocols are going to ring bells, and we're going to get blood cultures back, and it'll show gram-negative bacteria, right? So it'll show E. coli being the most common bug that will grow in the biliary tree. Okay, so again, hemoglobin is broken down into heme and bilirubin, and that gets conjugated in the liver. And this should get excreted further into the biliary tree, but the biliary tree is inflamed or occluded by a stone, then we're going to have that bilirubin is just going to back up into the bloodstream, right? And we're going to have a rise in our T bili. All All right, diagnostic tests. So we talked about, T-Bili, AST, ALT, and other things. What are some other things we can do? Are gallbladder ultrasound. And again, that's better than a CT scan. So a CT scan is gives you a lot of good detail, but gallbladder ultrasounds they found were much more sensitive in the research, and that's what we should be using, right? And it could definitely tell us if we have a calculus cholecystitis, not calculus like math, but a stone, right, in the gallbladder that's causing it to become inflamed or itis, right? So they can look in there and they can see the stone, and 95% of the time they can see it. And also, like I mentioned, when they do a ultrasound of that right upper quadrant, if they get pain, that's called a sonographic Murphy sign. There's 90% chance that, oh yeah, you got a gallbladder situation happening. If we're just me scanning you with an ultrasound, which is non-invasive, causes pain, that's very, very likely that it's going to be your gallbladder that's involved. So what they're going to see on ultrasound, they're going to see a distended gallbladder. So gallbladder is much is bigger than it should be. They'll see like the gallbladder walls might be a little bit inflamed. They may see sludge in there. They may see stones, but that's going to be what we see with a gallbladder ultrasound that has a stone inside of it, right? So a thickened wall, pericholecystic fluid. And unfortunately, that can happen with volume overload as well. So it's just like with a grain of salt, if you give like 6 liters to the patient, you can also have a little extra fluid in your gallbladder and a little extra gallbladder wall thickening when that happens. Also, ascites and hepatitis can do that too. But having those labs can help us out and let us know for sure that the gallbladder is involved. Again, this is a cholecystitis from a stone in the way. It's trying to squeeze out, and it's under pressure, and that's going to cause the pain from in that right upper quadrant, right? I keep changing the color to red, but there we go. All right, and then we have some other less common things, but are deadly, and reasons why we see these patients in the ICU, because someone with a gallbladder issue, they go to the floor. There's no reason to admit to ICU unless they develop ascending cholangitis, right? We've really talked about that guy, right? Ascending cholangitis is pretty, not common, but in the ICU, from ICU perspective, as far as patients coming to the ICU with gallbladder problems and gallbladder sepsis, it's, if you had to bet odds, it'd be ascending cholangitis. Okay, and how do you know you have ascending cholangitis? Well, we have the common bile duct is dilated, right? Right down here, we got a stone in the way, and it's dilating that duct, right? So we've got that stone that's dilating the duct, and it's making it not CBD oil, but CBD greater than 7 millimeters is usually diagnostic for a choledocholithiasis. And then you can get gangrene, right, of the gallbladder. That's one that has been treated for a while. All right, a dead gallbladder. They're not going to have Murphy's sign because it's kind of dead and shrunk. So, but it can definitely cause some infection, and because gangrene, as we know, or necrosis, as we know, is a prime ground for infection to brew. Okay, so it might like irregular wall thickening. It's very sneaky to be able to assess that this is that is the only problem with the patient. And then emphysematous cholecystitis happens in elderly, and happens also like diabetic patients. They'll have it's very difficult to distinguish as well. They probably need a CT scan once you see, I forget the findings. You're going to see like some air findings in the gallbladder. The wall be irregular as well, but it's extremely hard to detect that this is present, right? And then cholangitis, that's sneaky to the max. That is where it is, yes, you can see common bile duct dilation, but it may be negative. So we really have to use, clinical suspicion to think that, hey, they got fever, they got right upper quadrant pain, they got jaundice, T-Bili is elevated, what else can we do? It's like, oh, I can search through my notes. How about GGT? That's only found when my biliary tree is blocked. Okay. And then if we really can't, we really want to see that biliary tree is blocked, we have a nuclear med scan that we can do. So the P-HIDA scan, just like all nuclear med scans, you look at the magic eye from the 90s. You got to put your face close. You got to pull back, be able to see that. Oh, I do see that the biliary tree there. It's like, okay, more power to you, right? So you either see that I went for the gallbladder through the sphincter of Oddi, and they could see that there is clear passage. If there's clear passage, there wasn't blockage, right? But if it stopped halfway through, or stopped at the level of the stone, then that tells us that the P-HIDA scan revealed that there was blockage, right? So P-HIDA scan is tagged bile that they'll give, and it will then be injected, and we'll then scan them a couple times to see the flow through the biliary tree, from the liver to the gallbladder, all the way through the tree. So it takes about 60 minutes for this to happen, right? Over 60 minutes. That's an exciting 60 minutes. You have to make a lot of small talk, right? But they inject it and they track it, right? It's called a p-HIDA scan because of this long word right here, right? Hydroxyamino-diacetic acid is what they're going to be injecting, and they'll be able to track it all the way through. And to make it 60 minutes, they're not just going to wait for it to happen. They're going to say, I'm going to give you cholecystokinin, right? CCK, we know, is the natural hormone that makes your gallbladder contract after a fatty meal. So that makes sense. They give that, and they also give morphine to contract the sphincter of Oddi. It's like, see, I told you. It's like, yeah, but it doesn't like worsen pain or worsen outcomes. But they do that to assess the overall biliary tree. Okay, and then we have ERCP. So ERCP is a good diagnostic test, because you can go in there with the camera. It's like, oh, there it is, I see it. And then it's also a intervention. So not only does it diagnose that you have a choledocholithiasis, but also you go in there, there's a yoink, you can just yoink it out, right? And we saw that picture with gallstone pancreatitis that comes out, and it's like a huge relief, right? It's like Pimple Popper MD. All right, so that's the idea. So HIDA scan is kind of, we don't really know. Ultrasound was inconclusive, but really it's the ERCP that's going to help us figure out that we have a stone blocking the bile duct, right? And yeah, it can be very, very sneaky, and so can like a gangrenous one or emphysematous one. So we have to be, alert for the lab changes and the patient's overall condition. If they're getting shocky and they're getting more tachycardic, more tachypnic, more febrile, and they're getting more confused, well, shock and confusion equal, and those other signs of gallbladder stuff tells me I have ascending cholangitis, right? Which could be what? Very, very sneaky. So treatment, like I mentioned, the ERCP can only diagnose your gallstone, but it can also tell you that you have it can also intervene and take out the gallstone, right? So it can remove the stone. You can place stents in place so that the biliary tree stays open. The patient does have to lie prone for the procedure, so it's not like great for an ICU patient to go for this procedure if they're intubated and such. So if they're super, super sick, they may be intubated. It can be done. All right. So basically, they do need to do source control to take out this stone, because that's causing all of our problems in the first place, right? So complications with a ERCP, we mentioned before pancreatitis. Ironically, gallstone pancreatitis is caused by a stone, but if we do the treatment for that, which is taking out the stone, that can also cause pancreatitis. Okay, and then bacteria could translocate as we're instrumenting in here. So we have the stone in here, and we're going to go ahead and use all of our instruments. They might not be super sterile. We might cut through some stuff. So that can cause some sepsis process in of itself, and cause bacterial translocation from the bowel up in the biliary tree, and it can cause problems in of itself. But it does help, is 90% effective overall. And if a patient is really sick in the ICU, they can do something with IR. It's called a percutaneous ERCP, or a transhepatic cholangiography, where they're placing a drain through the skin into the gallbladder, right? And they're just placed in there to drain the gallbladder, because the gallbladder might be inflamed, or might be gangrenous, it might have an abscess, or might be something there that we need to drain out of the patient, right? And it's usually for your sicker patients. Unfortunately, it can stay in for like 21 days or something, and you really have to say, can you go to surgery now? How about now? Surgery now? Can we go to surgery? How about now? Today they're doing good. Everything's fine. My leaf has only 4 mics. Can you go now? So it's up to the surgeon to take it out, and then of course it's like a temporizing measure to then take out the gallbladder. So you can imagine if you have like this much infection, right? We're going to reduce it by 75%. So that's what's going to hopefully abate and fix the source of infection. Okay, just like when you have an abscess, right? We don't take out like a whole piece of muscle, right? We don't have to scoop out all of the skin. We just do an abscess IND to take out the source, primary source of the infection, a majority of the infection. All right, so it's a drainage bag. They can place stents in there a little bit, but it's going to be definitely the drainage bag is attached like an accordion drain. Have you ever seen an accordion drain? Right, they are going to be attached to a little bag. It's under a little bit of negative pressure, so it's pulling fluid at all times out of the patient. So it'll be like attached to this guy right here, right? What else? So percutaneous drain is placed, and what are the complications? It can spill, right? It can be dislodged. So one of these little holes can back up one little space, and now you're draining bile into this this abdominal space, right? So, doing not ultrasounds, but another CT scans to see if abscesses are forming would be a good idea if they're getting worse, right? And they usually get better in 1 to 3 days. If they're not, then we'd have to probably rescan them to see what might be happening, right? The drain might have moved with all of our aggressive and excellent bed baths, right? That might have happened. We don't know. Liver abscesses could form, which now is involved in the liver. The portal vein could get inflamed that's nearby, and that can then cause it to form thromboses, which is going to cause portal hypertension. The pancreas can get inflamed, and of course we can develop ascending cholangitis. So it's not without its risks. And of course they have to have a clear shot. They can't be going like through a loop of bowel. They have to be able to see clearly. If they have ascites, that's not going to be easy as well, right? They may be stuck with the drain until they are an operative candidate. Okay, so we want to get all this stuff on board. We get antibiotics going. All right, so the strong stuff. Why is ceftriaxone not there? Not ceftriaxone because that leads to increased biliary stasis, right? Biliary stasis. So it's a great drug, but we are not going to give it because it's not going to help out. It's going to reduce the flow even more, and that's going to worsen our symptoms. Okay, so Zosyn's a great choice because it has anaerobe coverage, covers gram-negative, gram-positives. So does meropenem, right? So our gallbladder has doesn't get blood supply to the lumen of it, right? So we have to have something that's anaerobic to cover it. What else? So we have to, these are all of our things we can intervene with. And then we have finally a CCY, a cholecystectomy. Usually do it laparoscopically, but they might have to open it up. But definitely on the previous slide, we highlighted what was emergent, right? So ascending cholangitis is emergent. The emphysematous or gangrenous gallbladder is also an emergent thing that has to be fixed right now. You can't just wait and optimize them medically. It has to be intervened upon as soon as possible for source control. Okay, so here's some examples of some ERCPs. Let's take a look here. This guy we're going to slice open. I think it's the one I showed you before, possibly. That's going to be satisfying, I bet. Oh, little eyeball. Don't worry, there's no liver flukes this time. Just a huge stone. Oh, that's satisfying. That's a lot of gastric sludge behind it, right? This guy, we're also going to go up in there. We're going to take out some little stone, right? Oh, sorry, it's a worm. So that can also block your biliary tree. Oops, all worms.
That's the common bile duct up there.
Yep, the common bile duct that gets invaded by ascariasis, by eating raw salmon. I think these are the liver flukes. So I didn't bring them back, but they made their ugly return. But that's something that can happen. I think liver flukes actually is like the most common cause of biliary and portal hypertension outside of America. So it's very, very popular.
The parasites that you were talking about?
They're both technically parasites, but yeah, it's a parasite that can invade your biliary tree. All right, so acute calculus cholecystitis versus a cholangitis, ascending cholangitis. As we know, that's going to be our worst case scenario. We have ascending cholangitis, right? So cholecystitis, again, it's just self-contained, it's limited to the bladder. It's not going anywhere. We can put a drain in there. We can take it out. But it's usually going to have that biliary colic pattern. And patients usually respond well just like monitoring them. But if they start developing that triad, what's the triad again? They got a triad of J for jaundice, right? They got another triad for F for fever, right? That's like an F or J at all, but F or J. And what's the third one? P for right upper quadrant pain. Any one of those, those three things together really telling us we have a gallbladder situation. And it could be, now we're kind of progressed from just cholecystitis or cholelithiasis to a cholecystitis pattern, right? And that's where they get the antibiotics and they get, they might get surgery done, right? And just cholelithiasis has like a biliary problem. But when you have this triad and it progresses to what? To a pentad, right? We draw a 5-sided shape. 1, 2, 3, 4, 5. Oh, good. Okay, I'm gonna mess that one up, right? So I kind of that should be one step higher. So this guy is up here, right? It has the triad, cholecystitis. The pentad is your ascending cholangitis. That's the worst case scenario. That's never self-contained. That's not something you just ride out. That's something as a medical emergency that needs to be fixed immediately, right? We need to fix that because bacteria have traveled all the way up the biliary tree through the liver and into the bloodstream. Okay, source control is what we need to do immediately. It might be a drainage placement, it might be a CCY, it might be a ERCP, if we could get in there and take out the stone. Okay, and then acalculus. I bring this up because this happens in the ICU. So acalculus is there's no stone that we can see, and there's no stone causing blockage, but it's due to just lack of flow in the critically ill patients. Patient that has a shock state, they're going to have the fever, right upper quadrant pain. They're going to have it's 10% of your cholecystitis patients. They're going to have this stasis that occurs, right? And it's also going to be increased with ceftriaxone as well, right? So something to be alert for. We're going to see a rise in which labs when you have cholestasis? You have a rise in what? Lipase is going to be pancreatitis more, right? But it's going to be a rise in your T bili for sure. Be a rise in your, what else? T bili, and what's the other popular lab is your Alk Phos, right? So Alk Phos and T bili really kind of point you towards a direction, especially if we have a triad or a pentad on our hands, right? So how do we avoid a patient that's going to develop this ICU-induced cholecystitis? We make sure we get good perfusion, excessive opioid use, which shuts down the whole GI tract. Make sure they're getting fed, right? Make sure we got good perfusion, MAP greater than 65, and get them off the ventilator so they can get better discharge from the ICU, right? Then it didn't happen on our watch. All right, so that's the idea behind this, bile stasis, and can lead to ascending cholangitis, or it can be increased pressure due to a stone blocking, which can cause the cholecystitis, right? And we talked about the treatments for these. Biliary colic is just pain. Cholelithiasis, usually just pain, but when it starts blocking stuff, that's where we're going to get cholecystitis. And then it can progress down the duct to cause choledocholithiasis, and that can ultimately lead to our worst complication of ascending cholangitis. All right, so which one's the pentad? That's this guy down here, right? And our triad was choledoco, cholecystitis. Cholelithiasis may have a triad, but it's usually, just the stones are present, and it might have some biliary pain, biliary colic, but it's not emergent immediately. But what needs antibiotics is definitely something we're in this zone down here when it starts causing some itis.